Well, good morning. First and foremost, I'd like to welcome all of you to the offices of the National Resource Center for Hispanic Mental Health. My name is Henry Acosta. I'm the executive director of the organization, and I'm also the project director for a project called Partners for Culturally Competent Behavioral Health Service Delivery to Hispanics. I know, a long name. I apologize for that. With me today are Dr. Peter Guarnaccia and Dr. Igda Martinez, who you'll hear from throughout the day and part of their training in just a few minutes during their introductions. I just wanted to take an opportunity to welcome you to our training. As many of you know, today's training is part of a videotaping session for an online training toolkit that we are creating for a web-based learning program that's aimed at helping organizations learn how to better attract, engage, retain, and serve Hispanics in mental health programs. So I really thank you for being here, especially on a Saturday morning. This is Dr. Guarnaccia and Dr. Martinez are experts in trainings. They like to ask a lot of questions and engage the audience, so I encourage you to ask as many questions as you can. And there were a lot of handouts that were part of your signing in. For those of you, just to go over a couple of things, you have your PowerPoint where you're able to take some notes, and there's also a couple professional journal articles back there. And then I also included a handout of NAMI's magazine, NAMI's the National Alliance on Mental Illness. They have a magazine called Avanzamos, which is a bilingual publication. And then lastly, I included a manual and a curriculum guide, which is a guide used to engage Latinos' readiness to engage in psychosocial rehabilitation. So you're more than welcome to take the manual, and I have much more of these as well, the actual program book that's used by clients. So if you want some extra ones, just let me know after the event. And you'll hear more from me later in the day, but I wanted to thank you. I wanted to officially welcome you all to our offices and to thank you for your interest and your commitment to eliminating disparities that exist for Latinos in accessing and receiving quality mental health services. So with no further avail, I'm going to introduce Dr. Peter Guarnaccia and turn you over to some great hands.
Great. Good. Well, welcome everybody. So I'm Peter Guarnaccia. I'm a professor at Rutgers University, a medical anthropologist by training. I've been working on cultural competence issues in New Jersey for many, many years. Charles and I were talking about that. I think I started on the Multicultural Advisory Committee in 1981 and do a lot of research in Latino mental health issues. Dr. Martinez and I have worked together for at least a decade on these issues, and the papers that we gave you are two papers that we've co-authored that will form some of the core of what we'll be presenting today. So to give you a sense of the agenda, in a minute I'm going to talk about assessing diversity among Latinos. Igda is going to talk about some of her work and our work on depression and how Latinos think about depression. Then we'll break for lunch, and in the afternoon I want to talk about the DSM-4 and the cultural formulation, although it's about to be ancient history since they're working on DSM-5 as we speak. And then genograms and some different issues around assessing Latinos, how to assess their diversity. But I thought I'd start with just two quick cultural questions. So to test your Latino knowledge, what do you call the shirt that I'm wearing? Guayabera. Guayabera. And why am I wearing a guayabera? I'm actually not from Cuba. My father is Sicilian Protestant and my mom's German Jewish. They were both Spanish teachers, so you can become an expert in Latino cultures and language without being Latino. But it's, now that it's warm out, instead of wearing a suit like Henry, I get to wear a guayabera and I don't have to wear a tie. It's a very formal. And what is today's date about? And what is the Cinco de Mayo? The Battle of Puebla. And where is Cinco de Mayo celebrated? Mexico. Okay. And the interesting thing is that Cinco de Mayo is actually, there was just an article yesterday in the paper, it's actually a bigger festival here in the United States than it is in Mexico. Some people think it's Mexico's Independence Day. That's actually in September. And 2 years ago was the 200th anniversary of independence and the 100th anniversary of the Mexican Revolution. But the Batalla de Puebla is actually when the Mexicans beat the French. So believe it or not, the French actually occupied Mexico for a while under Napoleon. In fact, the article I read yesterday said Napoleon had designs on the US too, and had the Mexicans not beaten Napoleon at the Battle of Puebla, or the French troops, he might have gone to the United States, so we can thank Mexico for the independence of the US from France. And the guayabera, although this guayabera I actually bought in Mexico, I now take a group of students, is more typically worn in the Caribbean, in Puerto Rico, Cuba, Dominican Republic, but you can see it being used throughout. So I want to talk about diversity among Latinos because I think it's really important as we think about doing clinical work with Latinos to understand just how diverse a group it is. And I want to start with the census questions because, in fact, the census questions are terrible, and they treat Latinos as if they're some sort of homogeneous group, or even that Latino is a real label. But I think it says, is this person of Hispanic, Latino, or Spanish origin? And actually in the census, this question is the first question. It's called the ethnicity question. And in a minute, I'll show you the race question. And then the answers are, you could say, no, not of Hispanic, Latino, or Spanish origin. Yes, Mexican, Mexican-American, Chicano. Yes, Puerto Rican. Yes, Cuban. Yes, another Hispanic, Latino, or Spanish origin, and print the origin, for example, Argentinian, Colombian, Dominican, Nicaraguan, Salvadoran, Spaniard, and so on. Anything strike you as sort of odd and unusual about this question? What strikes you about this question?
Why do they put like Mexican, Puerto Rican, and Cuban in a different one?
Why do they, so why are these three groups separated out from all the other groups? Anybody have a guess?
Cuban. I mean, Cuban and Dominican, and they're all within the same island.
So these are the three biggest groups. And these are the ones that have been recognized, although actually Cubans probably are not the biggest, the third biggest Latino group. Dominicans probably are now. And Ecuadorians and Colombians are fast approaching. But this sort of shows the politics. The other interesting thing, what does Chicano mean? What's a Chicano as opposed to a Mexican or a Mexican-American?
How about Guatemalan and everybody else? Where are they?
Well, they're there. You can write them all in. But what's Chicano mean?
It means Mexican American. Person who is of Mexican descent who is raised in the United States.
Mm-hmm.
Only in Texas, in the southern part of the
So it refers, and it's a more political label. Anybody know what the political label for Puerto Rican is? Have you heard the term Boricua? Right. So, and who uses Boricua? Puerto Ricans, and particularly Puerto Ricans who tend to support independence. So it's interesting that they use political labels for some groups, not for other groups. And then, as you point out, all the other groups are kind of left out, although you can fill in the blank there. Then they ask, what is this person's race? And it's white, black, African American, or Negro. Oh, just the other thing I wanted to note about this is Spanish. How many of you think a Spaniard living in the United States would label themselves as Latino? Why not? They're European, so they don't identify. And they're, in fact, the colonial country. So, so then white, African American, black or Negro, American Indian, Alaska Native, print name of enrolled or principal tribe. Then we have a lot of Asians, Asian Indian, Chinese Filipino, Japanese Korean Vietnamese, other Asian, for example, Hmong, Laotian, Thai, Pakistani, Cambodian, you can write in here. Pacific Islanders, we have Native Hawaiian, Guamanian or Chamorro, Samoan, other Pacific Islander like Fijian, Tongan, and then some other race. What do you think Latinos do with this question? What does this mean?
Skip it.
Skip it. Okay, why do they skip it?
Because it doesn't pertain to them.
And why doesn't it?
Because they're Asian.
What is
Well,
what?
I guess because they've already had the first question.
Okay, so they've already had the first question, but they are expected to answer this question.
So you have to check off whatever you are first, your race, right? And then
Your ethnicity first, so Hispanic. So where do you think Hispanics put themselves?
other.
A lot of them put themselves other, and they write in Hispanic here. Why don't they put a race. What's the thought about that?
I don't know, but there are a lot of Latinos who are black, but they don't consider themselves black.
Okay.
They don't see themselves as black, but Latino or Hispanic.
Okay. So they see themselves with the ethnic identity.
Or ethnic instead of race?
Mm-hmm. That's the way the census talks about it, as ethnic instead of race. A lot of Latinos would say, well, I'm white, I'm black, and I'm American Indian, so what do I do? Which box do I choose? Or they might say they're white, American Indian, and Asian. So there's a lot of confusion in these labels. And the point here is that I think as you think about creating your forms for your own clinics, don't get locked into the census categories, which happen so often, because they create a lot of confusion and a lot of problems. Now there's some other, anybody see any other issues with these categories? Why does white only have one category? Why do you think white only has one category?
It's sort of exclusionary.
Uh-huh.
You know.
Right. We're the reference group. We don't need a lot of categories. I mean, nobody asked the whites to fill in, you know, Italian, Greek, whatever. We're just white. Interestingly, black African American, and I think it's very interesting that they've kept the label Negro there. The census argues that there are still among an older generation of African Americans who identify with that label. But they don't also ask here for people to give a specific group. Like, are you African American? Are you Jamaican? Are you, Haitian? And then anybody know why these groups are the Pacific Islanders that are selected, Hawaiian, Guamanian, or Samoan? So a little bit of our US history. These are all still protectorates of the United States. Now, Hawaii's a state, although it wasn't. But Guam and Samoa are US protectorates. So we still own those islands. So these peoples are special, and then these others, the other Pacific Islanders, are independent. So there's a lot going on in these questions which don't usually get talked about. But the point I want to make here is that it's very important when you think about how you're going to collect data on who people are, that you know some of the history behind the standard census questions and why you might want to ask the questions differently. And now what I want to do relatively quickly is share with you a bunch of information from the National Latino Study. So there's this issue of Hispanic and Latino, and you'll notice that I tend to use Latino when I can. Latino tends to be, among Latinos, the preferred label over Hispanic. Actually, the preferred label is Dominican, Salvadoran, Puerto Rican. And if you're Puerto Rican, then you want people to know that you're from Ponce, or you're from Caguas, or you're from, but Hispanic, because it was the census category, and most of the federal government data is reported as Hispanics, has become kind of a resisted label. Also resisted because many people feel like it only reflects the Spanish heritage of Latin America, but not the other heritage, the Indian and the African that are there. So people prefer the term Latino. This is actually probably already a somewhat dated slide. This is from the 2000 census, but just to give you a sense, New Jersey is somewhat unique in its Latino population in that Puerto Ricans are still by far the largest group. In the United States, Mexicans make up about 60 to 65% of the Latino population. Puerto Ricans are around 12 to 15%, and we don't really know the percentage of the other groups because they're moving so fast and we don't keep good data on them. But at least in New Jersey, Dominicans are the second largest group after Puerto Ricans. Mexicans are actually the third largest group, then Colombians, and then we get to Cubans. And one of the interesting dynamics in New Jersey is that Cubans have been leaving New Jersey in large numbers. and going back to Miami or going to Miami to rejoin family as they get older. They don't like the cold winters in New Jersey. And so we see a decline actually in the Cuban population and rapid rises in Colombians, Ecuadorians, Peruvians, and then also Central Americans. But depending on what community you're in, so for example, in New Brunswick, anybody know what the biggest group in New Brunswick is for Latinos? Mexicans, right. So Cinco de Mayo is going to be going strong later today in New Brunswick. We have 13 authentic Mexican restaurants, last count, almost all from Oaxaca. So these are the general trends, but some of you are from Patterson. So what's the big group in Patterson?
Dominicans are large group, and
Mexicans have been growing in Patterson.
the same county, especially the same city.
Uh-huh. Many of the Mexican products that are made here now, like the tortillas, come from Patterson, Passaic area. So, but North Jersey still tends to be a home for Caribbeans, Puerto Ricans, and Dominicans. So where you are, there's a big Honduran community in New Brunswick as well. Costa Ricans are big in Bound Brook, New Jersey. So depending on where you are, it's really important to figure out who's your local community and what are they like and what are the important issues. So I want to share some data from something called the National Latino and Asian American Study, the NLAS, that was done now about 8 years ago. It was started. It's the only nationally representative sample of Hispanic Latino mental health in the United States. So this is a US sample. And it was funded by the National Institute of Mental Health. It was part of a series of big studies of mental health in the US. They had a good response rate. It was 2,554 people participated. You can see that the biggest group is Mexicans, but actually, if we had done the proportions as they actually are in the population, the Mexican sample would have been about double that. But then the other samples would have been too small to analyze. So we tried to have balanced samples, but to know how they related to the national sample so we could look at them. So it was, we were stuck with the 868 Mexicans, 577 Cubans, 495 Puerto Ricans, and 614 everybody else. So we unfortunately did continue that tradition in part. Part of the reason we have so many Cubans is that you just go to Miami and you sample in Miami and you get the Cuban community in the United States. So it's relatively easy to get them. And that's, I think, another unique feature is that Latinos are not evenly distributed throughout the United States. And how many of you have been to Miami? So Miami is the capital of the Caribbean. Or it's the northernmost city in Latin America, I think of it, rather than the southernmost city in the United States. It's really a very Latin American city. And in fact, I would say the first language there is Spanish. Cubans control the economics and politics of the city. So it's a very unique city in the United States. San Antonio has somewhat that flavor for Mexican Americans. And interestingly, although Puerto Ricans have actually been in New York City since the 1920s in a very large group, they never got the economic and political control that Cubans did in Miami or Mexican Americans in San Antonio. So that also creates some different histories and different dynamics. So just so you know, the NLAS used bilingual bicultural lay interviewers, so they had a whole team of interviewers who could interview on the spot in Spanish or English. The analyses I'm going to share with you are all weighted so that they actually are weighted to the national population. So let me quickly, all these slides have the same format. So this sort of rust yellow bar is the total sample. The red bar is Puerto Ricans, the blue bar is Cubans, the gray bar is Mexican, and the light blue bar is other Latinos. So we're going to keep that format. So I want to just run through these data because I think it's important to get a sense of even at a national level, we can see a lot of diversity in the Latino community. So for example, the Cuban community is the oldest community. One of the things that's really striking to me is even though we did this study not so long ago, there's still relatively few Cuban adults who were born in the United States, which I was surprised at because I mean, they started coming in the 60s, so you'd think there was a second generation, and there is, but not that many. You can see that in terms of youth, the Mexican population is the youngest population. So two of you are here from the school system, Patterson schools. So even if you don't have, even when Latinos may not be the biggest group in your city, they're often the biggest group in your schools. So like in New Brunswick, Mexican Americans don't make up a majority of the city, but in several schools they're now up to 80% of the school children. Yeah.
I work in a school where the majority population, 80% are Latino.
Uh-huh. And which groups are the most prominent?
I would say Dominicans.
Dominicans. Okay. And how many of the professional staff, teachers, social workers, administrators speak Spanish?
Some, they're either teaching bilingual or ESL.
Uh-huh.
The ones that speak Spanish teach either ESL or bilingual.
And how about the history and math? And
We do have a math teacher who's from Colombia.
okay. So I mean, when you think about that 80% of the kids are Latino, the school is really a bilingual school. And so the whole staff in some ways should be bilingual. Yeah.
I'm in preschool, and even in the preschool you see the same thing.
Uh-huh.
That most of the children are Hispanic.
Right. Well, and that's because there's such a young population. When you look, I mean, you know, overall, almost 50% of Latinos in the U.S. are of the adults were in the 18 to 34 group. We didn't look at kids in this study. Gender, pretty equal, except you can see for Mexicans, slightly more men than women, and for other Latinos, slightly more women than men. But I think the Mexican data, the main point I want to make here is that although this has changed a lot in the last decade, there were a lot of Mexican single men coming to work. If you go to the restaurants in New Brunswick, you see a lot of them. But now there are many more families, and this is, again, reflected in the school system. Education, the Cubans, the dark blue bar, are the most educated. They have the highest proportion of people with more than 16 years of education. You can see that Mexicans are underrepresented in the 13 to 15 years, which is college. Interestingly, Puerto Ricans in terms of college are higher than Cubans, but that's because Cubans have a bigger group over here. And less than 11 years, you can see that Mexicans are way overrepresented. So one of the important features is that, particularly among adults, because of the opportunities for education in Mexico. So I now take a group of students to Oaxaca in the summer to study community health. But one of the features that's still true in that almost all rural schools in Mexico have a primary school, what they call primaria, which is up to 6th grade. Very few have a secondary school. So for kids to go to high school, they have to travel to a bigger city, and that can be difficult to do. And so you still see a lot of Mexicans with only primary school education. Why don't you see so many Puerto Ricans with just primary school education anymore? Yeah.
It's part of the United States.
Right. So people don't realize that Puerto Rico is part of the United States. Puerto Ricans have been citizens since 1917, so you'll see that in a minute. All Puerto Ricans are citizens. So their school system is very influenced by the U.S. On the other hand, in the 1950s in Puerto Rico, the U.S. insisted that all education be done in English, even though people spoke Spanish. Now education is done in Spanish. So there was a lot of dropout from schools. So if you have older clients from Puerto Rico, they may have limited education because so many people in that particular time period dropped out of school. Income, you can see that there are, about a quarter of Latinos, slightly more for Cubans, make more than $75,000 a year. So again, the image of Latino community as a poor community doesn't fit. It's that the poor community is a part that we often hear about, but in fact, there are many professionals. And in fact, particularly the 1970s recession in the United States, they say when the United States sneezes, Puerto Rico gets a cold. What that means is that if the economic situation is not so good in the U.S., it's terrible in Puerto Rico. And in the 1970s, a lot of professionals from Puerto Rico came to the U.S. because the economic decline, and I'm sure this is being repeated now with the current recession, meant that there were fewer and fewer opportunities for professionals in Puerto Rico. So you saw a big move of professionals. You can see that Mexicans, again, are overrepresented in the two lowest categories, which partly has to do with the resources they bring with them, but a lot the kinds of jobs that are available. And interestingly, if you interview other Latinos, a lot of them have professional degrees in their home country, but have not been able to translate them here. So they may have been lawyers or accountants in their home country, and here they're working in restaurants, cleaning, because they haven't been able to transfer those credentials. Cubans were helped immediately by the US government to do that, particularly the first wave. Again, there are many ways of Cubans to transfer their credentials. So they were much more able to be, if they were doctors in Cuba or lawyers in Cuba, they were able to quickly become certified as doctors or lawyers or other professionals here. So you see really big differences. But I think in terms of doing mental health work, it's really important to ask people about what they did in their home country and what their status was like, because one of the issues they may be facing is that they feel like they can't achieve what they did at home when they come here. Citizenship, well, here you see that all Puerto Ricans are US citizens. That's the point I made before. But more than 50%, even of Mexicans, are US citizens. So this image that the Latino population is somehow an undocumented population is simply false. The majority of all Latinos are citizens. And then about half this group of not citizens have green cards and legal permanent residence. The other half are undocumented. So it's not by any stretch the majority of Latinos who are undocumented. But if you hear about, I mean, particularly with all the laws in Arizona and Georgia, you get this impression that somehow there are just huge numbers of, I mean, there are large numbers of undocumented Latinos, but not by far the majority. And this is why there's so much concern about these laws, because essentially the issue is if you look Latino, someone's got... So how many of you are Latino? How many of you carry your passport with you every day? How about the non-Latinos? How many of you carry your passport with you every day? Yeah, so I mean, the idea that somehow if you were stopped, your headlight was broken and a policeman stopped you and said, so, document your citizenship status. I mean, none of us could. We don't carry our citizenship papers with us. How many of you carry your birth certificate with you if you were born? How many of you were born in the US? Okay, so for others it would be a passport or, I mean, and so the problem is that when the policeman stops you for your broken headlight, if you look Latino or sound Latino, so some people don't look Latino, but as soon as you start talking, you can, then all of a sudden it's where's your documentation? But if you don't, they don't ask. So that's profiling. I mean, that's why people are so concerned about the profiling issue. Because all of a sudden, all Latinos become illegal, exactly. And I think that's the one time I will use illegal to talk about undocumented immigrants, is because when the legal system sees them that way. So again, you can see, this is where I say more than 80% of the Cubans that we interviewed were born in Cuba, whereas again, it's only half of Puerto Ricans. So this is where I think people don't realize how many generations of Puerto Ricans there are in the U.S. You can see that very few have parents born in the U.S. And what's interesting is if their parents were born here, it tended to be both their parents. So interestingly, it's the second generation tends to marry each other. The other thing that we're finding, so when I talk about labels, it's like by the second generation, labels like Puerto Rican or Dominican don't make much sense. You know, you hear people talk about Cubi-Ricans, that is one parent's Cuban, the other parent's Puerto Rican, as well as mixes across the full range of ethnicity in the United States. So it's quickly, these labels quickly are getting out of date. Again, 70% of life, it's actually useful to find out when people migrated. It turns out that if you're a Latina, a Hispanic woman, and you came to the US after the age of between 21 and 25, your risk of developing a substance abuse disorder is 0. So by just growing up and being raised in a Latin American country, the values and ideas about sort of using drugs and alcohol that were instilled in you are so strong that you're never going to have a problem. I mean, the data is quite stunning. If you came here before the age of 6, either were born in the US or migrated before the age of 6, then your risk of developing a substance abuse disorder is pretty similar to the rest of the US population. So, you know, we need to think about what are Latinos losing when they come here, because there's a lot of protective features of Latino culture. But so it's really important to know when people came and how much of their life they've lived here. You can see that except for Cubans, most Latinos didn't want to migrate. It wasn't like they were really excited about the idea. It's that they felt like they had to for their own survival, and particularly for their kids. We'll see, to give their kids a better chance. Most of them didn't plan the move. Again, only the Cubans carefully planned the move. So again, a lot of times some of the adjustment issues that you're going to see have to do with the fact that, well, again, it depends on why they didn't plan the move. For a lot of Salvadorans, particularly during the Civil War, in the mid-1980s, I worked at the Latino mental health program at Cambridge Hospital, Massachusetts. We had a huge Salvadoran population. Many of them told stories literally that either the guerrillas or the army knocked on the front door, they went out the back door and never stopped running until they got to the United States. So some people didn't plan their move because they essentially were escaping violence and didn't have a chance to. Some people didn't plan it because they essentially came to visit relatives. This is a particular, I think, a common Dominican story. And they just didn't go back. So they didn't have a lot of stuff with them, and they weren't planning. Whereas Cubans, because they often had to plan their escape over long periods of time, did have to carefully plan the move. Also, this doesn't get at what resources people brought with them. But obviously, the less planned your move is, the less you've brought with you. And again, depending on, so knowing that story, getting that, the key point here is getting that story and finding out what was left behind, what they brought with them. Did they leave because of violence and fear for their own safety? All those kinds of things are really important when we think about mental health. So this gets at the reasons for migration. You can see that 90% of Cubans said the political situation. Interestingly, significant groups, but not the majority, to get medical attention. So they couldn't, in Puerto Rico, they couldn't get the medical or mental health help that they needed. They wanted to come here to get better care. Jobs are huge for Mexicans. And everybody agreed that the most important reason was improving the future for their children. And I think this is something that's really important to tap into, is that families came to make a better life for their children. And what we find over and over again is they get here and they don't know how to achieve that. they don't know how to make that better life. They have an idea what it is. They want their kids to get more education, to go to college. But when they get here, they realize that they really don't understand the system. And the systems don't often help them understand it. And I think this is, again, for those of you who work in schools, what secondary schools can do and need to do to help kids actually achieve the dream that their parents have is tremendous. And I could say more about that some other time. Again, very different, this idea of separation from family. Obviously, Cubans find it very difficult to visit their family. Though Lita was saying her dad is in Cuba now, so things are changing, back visiting his family. For some groups, like Puerto Ricans, it's not at all difficult. They talk about, it used to be that the Eastern Airlines flight, Eastern's now out of business, from New York to San Juan was called La Guagua Aria. Anybody know what La Guagua Aria means?
Local bus?
Huh?
The local bus?
The local bus, the flying bus. So it's like taking a bus from New York to Washington, except you went on a plane, so people would just go back and forth easily. So it can be very different. But one of the things in terms of mental health that we particularly find striking is that when somebody dies back home, a grandparent, an aunt or uncle, that can be really difficult if people can't go back, either for legal reasons or for economic reasons. So the fact that family is separated and that at these times of crisis people can't respond the way they would makes it really hard. So again, I think in terms of thinking about assessment, clinical assessment, people may come in crisis, and it may be because of something that happened back home. Again, looking at language, I think this is a really interesting issue. I want to go through these. I'm going to go through these quickly because of time. But what I just want to give you is to kind of keep track of how the pattern of bars. So you can see that here we gave people a choice. They could do the interview in Spanish or English. And again, the Cubans were most likely to take the interview in Spanish. And what I want to emphasize, if nothing else, is that you always hear this, if you don't learn English, you can't succeed in the United States. Well, Cubans have learned English the least, and they're the wealthiest and most successful. So, and I'm not at all arguing not to learn English. It's critical to learn English. But learning English is not a guarantee of success, and not knowing English is not a guarantee of failure. It really depends on the group, the social context, the kinds of pressures, the prejudices people are under. But you can see sizable numbers of Puerto Ricans and actually of Mexicans and other Latinos preferred the interview in English. And then I won't say, we gave people a choice. Some people said it didn't matter, and we actually randomized people then to an English or a Spanish interview. But then if you ask people, well, in general, on a day-to-day basis, what language do you speak? You can see that this is very bifurcated, Spanish-English. If we ask people in general, you can see that they're kind of clustered towards the middle, that they're speaking either mostly Spanish, mostly English, or both equally. So they're using both languages a lot of the time. And I think those of you who speak a second language, that makes sense to you. You're even in the same sentence. It's quite remarkable. You start in one language and finish it in the other. But 80% of Latinos spoke Spanish as a child. So again, I think this fear that somehow, when we look at this slide, people are using English a lot, this fear that somehow people aren't going to learn English. The reality is the real danger is that they're going to lose Spanish, and that they are losing Spanish, and that we're losing a huge language resource. But they're going to learn English.
I was going to say, in my school, we had a big issue with our Latino families. The children who are born here don't want to speak Spanish at all, and parents are, in big conflict because they want their children to learn Spanish, and the children are saying, don't speak to me in Spanish, I don't want to learn Spanish, I'm not speaking Spanish. They take Spanish classes, a world language, and they fail. They are just vehement about not wanting to learn Spanish.
Why do you think that is?
I don't know if it's peer pressure, just to acclimate with their peers or what it is, but they are just refusing. And the parents are in great conflict because they're just, I'm not speaking, don't speak to me in Spanish. They understand it, but they refuse to speak. They say, I don't want to learn Spanish, and I don't know what's really going on right now.
Right. So this issue about the kids not wanting to learn Spanish and not wanting to speak it is a big issue. Why do you think that is? What's going on? Racism.
I think they want to blend in, like she was saying, a lot of times they feel different.
Why do you think they feel that way?
Everything that's going on.
Because they're being made to feel that.
Yeah.
You're looked at, if you don't look like the rest of everybody who's in the school, or you don't act the same, even if you're from the, even if you're both Latino, there's a difference in how you present yourself, and so you want to fit in with everybody else.
Yeah.
I think they're being bombarded with media, images, just the, you know, I mean, you got people coming at you in 99 different ways. We're just bombarding you with, you know, dress like this, do like this, be like this.
Right.
You know, and it just gets overwhelming.
Yeah. And I mean, so there's this whole movement, the English only movement. I mean, the Constitution does not say anything about English being the national language. I mean, it is the national language, but so kids feel like they're going to be discriminated. Who here doesn't have an accent? We all have accents.
Brooklyn accents.
Right. I mean, so we all have accents. It's just that again, like in the census where white is this sort of unmarked category, the sort of Northeast kind of, I guess maybe Midwest, what they call sometimes a flat accent is the normative accent, and anybody who sounds differently. So there is a lot of stigma around accents, around kinds of speech. It's a shame that the kids feel that way. And I think it's also, it is a big mental health issue because they're essentially de-identifying with their parents. They're saying, I don't want to be like you. There's something the matter with the way you are because you speak Spanish and I need to speak English. So these conflicts, plus, you know, when we talk about, Igda's going to talk about more about family communication. I mean, what happens when the kids and the parents can't actually talk to each other, at least on a very deep level? The other challenge is that where kids are learning English is television. So they're learning Power Rangers English or Barney English, or, so then when they get to high school and we wonder why they don't have a strong vocabulary, they have the vocabulary that they've learned through TV typically. So I think these issues are really important. But I think it is, you know, I mean, I think one of the things that hopefully schools can do is to more encourage it. You know, one of the things that occurs to me, and I've actually been doing some work at Rutgers, is why not have, in Spanish class, have intercambios where the kids who are native Spanish speakers get a kind of valued position where they break them into duos and have the kids who are native speakers having conversations with the kids who are Spanish learners, so that the kids who are Spanish speakers feel like they've got some strength, some ability that the others don't have, and it becomes a value rather than a deficit. Did you want to make a comment, or? No? Okay. Again, language proficiencies, you know, depending on how you ask, people tend to have stronger spoken language ability in English. Again, there are a lot of bilinguals. You can see that the excellent bars are some of the tallest, but again, for Cubans, relatively poor English ability, and Mexicans, but a number of people who say they're excellent in both languages. Whoops, going the wrong way here. Again, ethnic identity. So people say they feel very close to their group in terms of their identity. But when you ask, is it important to marry people from your group? And we didn't get very clear. This is, I think, where, you know, is it important to marry another Puerto Rican if you're Puerto Rican, or another Colombian? Or is it just important to marry another Latino? But what we'll see is that as we get to the second and third generation, very different mixes, and many people marrying across Latino groups and then with non-Latinos. This scale shows that there's a fair amount of acculturative distress was a set of questions particularly around fears of immigration status. So it's not surprising that Mexicans are the highest on that scale. Family cultural conflict I'm going to skip over because Igda is going to spend a lot of time on that. But what was interesting is that we asked people if they were back in their home countries on a 10-point scale on a ladder, where would they be in terms of social position? And by social position, we didn't just mean wealth. We meant prestige, status in the community. And then where do they think they were here? And so this is what I was talking about. Look at the other Latinos. They declined in social position by coming here. So this is the sacrifice parents are making. They're losing their own social position in the hopes that their kids will gain. Only Cubans saw an increase in their social position from leaving Cuba to coming here. Puerto Ricans also a big decline. So I think this issue of what parents are sacrificing. I'm going to skip over this except to say that what I wanted to emphasize here and hope I have is that there's a huge diversity among Latinos, that there's a lot of clinically relevant information just in finding out the demographics. So when you fill out your forms and you ask people their age and other, language, I mean, you're not just checking off some boxes, or you're even asking them the race question. You're tapping into really critical issues about people's lives, and it's important to get to know some of the material behind it. I think this issue about, why kids feel like they don't want to identify with at least their language is a really critical one, and one to explore more as we go along. So we're running a few minutes behind, but let's take a quick break to just...
So I'm going to be talking now about cultural issues and Latinos' experience with depression, okay? Before I get started, the reason why we chose depression is because, as most of you I'm sure know, it's one of the most common mental health disorders that's experienced by the population in the United States. One of the things that we like to do is to use the exact words from our participants in our research to really capture what their experiences are like. So I'm going to read this quote in Spanish and describe it in English. One of the things when we talked about with our groups is, what leads to depression? How do you end up in that category of adults suffering from mental illness with depression in particular? So one participant said, actually what I'll do is I'll just explain it in English. You can read it in Spanish if you can. It's like losing the roof over your head, losing everything. It's as if one had gone through an earthquake and lost everything. It's an accumulation of losses. So we thought that was a very poignant, very descriptive way of really capturing what that experience is of going through depression and the particular link between migrating to the United States and experiencing depression. The goals of the research that I'm going to talk about were, first and foremost, to get a richer understanding of the concepts of depression within the Latino community. We wanted to have a fuller understanding of the attitudes towards, concerns about, and expectations regarding treatment. And we wanted to identify the barriers to care from the perspective of community members themselves. The methodology that we used for this particular research was based on 4 different projects across New Jersey and New York. We were looking to examine the conceptions of mental health treatment and barriers to care, as I just mentioned. One particular aspect of the study looked at elderly Latinos' understandings of depression and their reactions to standard depression measures, so checklists that people use sometimes in clinics to assess depression. Looking at community concerns about health and mental health, as well as assessing the services that they felt they needed. And recognizing, or the recognition of depression in the community, as well as attitudes towards care from the community. We had 94 participants overall. We used the focus group methodology. Again, this was in both New York and New Jersey. Are you familiar with the focus group methodology? It's a group format where we invite community members to come in, usually between 8 to 12 folks. And it's a discussion that's led by usually Dr. Guarnaccia, who has sort of ideas of general topic areas, but the idea really is that the conversation comes from the participants themselves. So we don't necessarily lead them, but we have sort of general topic areas to get the discussion going, and then we see where that leads from the participants themselves. We had a diverse group of Latinos in terms of country of origin, their time in the United States, their age, their gender, and their level of education. All groups were held in Spanish. They were facilitated by Dr. Guarnaccia. They were led by Dr. Guarnaccia and facilitated by myself. So one of the main things that we wanted to get, that we used to get the conversation started was asking community members, what's mental health, right? We all know what's being crazy, or we think we know what's being crazy, what's mental illness, but what's mental health? How do you define that? So one of the things that, the main key points that arose from these groups was that social relationships and supports were key aspects of mental health for the Latino community. Mental health was defined as being able to function in and contribute to society. So there's a real value placed in being an active participant of your community. It was being able to live una vida tranquila, so a tranquil life, a life at ease, right? Being in control of one's emotions and not being aggressive. That was a very key point that a lot of folks mentioned in our participations. And also not abusing alcohol or drugs. So would you agree that this is kind of a good definition of mental health? Yeah, so it's basically, you know, being at ease, being able to participate in your community, not having any addictions. These were some of the specific comments when we asked about this general idea, what is mental health? A good life would be living a tranquil life, being in good health. That's the most important. To feel a sense of well-being about my family's unity and to live peacefully. My family's unity, right? So here we get into these concepts of sort of community collectivism, about family importance, and this was mentioned a lot in our group, by our group participants. So moving now into mental illness and specifically what is depression. The major concepts that were recognized by our participants were that depression was, first of all, widely recognized among Latinos as a mental health problem. So they did recognize it as a problem. They recognized both the emotional aspects of depression as well as the somatic aspects of depression, meaning the way that, you know, depression can manifest itself in your physical body. Depression was seen as a result of social stressors and losses. So here we go back to that first quote that I used to start my presentation. Death of a family member was recognized as potentially a trigger for depression. Isolation and loneliness, which is a part of leaving, you know, some of the things that Dr. Guarnaccia was speaking about earlier, leaving family behind when you come to this country. Loss of a job or financial stresses, so the insecurity of the types of jobs that are available when you migrate here. And another example that was very particularly pertinent at the time that we did these focus groups were the events of September 11th. Depression was often connected to diabetes. So there was this understanding within the community that the physical ailments and mental illness were oftentimes linked. Also other conditions such as high blood pressure. So there's this mind-body connection that is very fluid that it might not be so in other communities. But it's important to keep that in mind when we're talking about Latinos. So again, I'm going to use some quotes to really highlight the way our participants viewed depression. One person described it as a person being sad, nostalgic, cries easily, feels very tired and doesn't know why, has no desire to do anything. One doesn't have friends, doesn't have family or anything. When you feel like this, you miss your family even more. So here we have a community participant who's essentially describing the checklist from DSM, correct? Right? So again, this really highlights the fact that depression is very much recognized in the Latino community, as opposed to other viewpoints, perhaps, that maybe Latinos weren't getting mental health treatment because they didn't recognize depression as a problem, but they do. Another participant said, men get depressed. They seek out alcohol to escape and not deal with their depression. They're responsible for their family here and also have to send money to their family there. And finding work here is difficult. Again, so here we are looking at the very real life consequences and struggles that our Latino community members are struggling with that can lead to or contribute to depression. In this particular case, we talk about the gender differences and how men perhaps might seek out alcohol as a way to cope with their depression, with the mounting responsibilities of having a family here in the United States as well as in their home country. We asked them about barriers to care. So, okay, you know what mental health is. You recognize depression as a problem. What makes it difficult to get treatment? One person spoke about personal experience. I never received the counseling. They were offering me the counseling and I went and I presented myself, but they said, no, your husband's insurance doesn't cover this. We need a $250 down payment. So that's the reality, right? So they come in, the first question when you go to any clinic is, can I see your insurance card? Right? So that's a problem if you're underinsured or not insured at all. And then $250, that's not, you know, pocket change. So that makes it very, very difficult for Latinos to receive services. Another person said, we immigrate here and we find ourselves with many barriers, such as language. We don't have papers. We don't have information about many things. We don't know what our rights are. Life here is very difficult. We're very isolated here. So even if they come to this country, if they live in one of these communities that's an ethnic enclave, it's very close-knit. It's very sort of us versus them. And then outside of that, where do you go? How do you get there? Literally, how do you physically get there? Where are the clinics? What are my rights? If I'm not documented, can I still get services? There's a lot of questions in the Latino community about mental health treatment. And this is something that we as providers need to make sure that we're answering these questions when somebody comes into our clinic, that we're letting them know exactly how we work, you know, what they can expect. Attitudes towards seeking help. We asked them about what they thought mental health treatment was and whether or not it was something of value for them. One person said, in the Hispanic culture, we think going to a psychologist is only for people who are really crazy. It's due in part to ignorance, not being able to understand depression, and not knowing where to go for help. So in the human condition, right, we're afraid of the unknown. So maybe you realize that you're feeling sad. Maybe you realize that you're lonely, that you're losing your motivation, you don't feel the way you used to feel. But what do you do with that, right? And then there's the fear. Wait, if I go and I talk to somebody, people are going to think I'm crazy. Stigma is a huge barrier to care, and it really influences the decisions that people make. Then we asked specifically about their attitudes towards providers, the people who actually give the mental health treatment. Most of our participants stated that if they do seek help, they're more likely to seek help from their primary care providers, right? So they'll go to their regular PCP, their doctor, because they are not aware of mental health as a specialty service. Perhaps that's not the way the infrastructure is in the health politics of their country of origin. Language barriers and cultural issues in understanding the American style of mental health treatment, and I'm going to give some examples about what that means. And also, there's a need to be accessible, meaning, are you close to a bus route, a train stop, are you within walking distance from my place of work? To build trust or confianza, that's a huge aspect of what makes a good provider. And to treat people with respect, respeto. Again, these are sort of values that are very, very important in pretty much all communities, but particularly in the Latino community. And it's something that came up time and time again as we were speaking with the different participants in our groups. One participant said, I've gone to several psychotherapists. I went to one who sat down and said, talk. And it felt like I was talking to a wall. But the one I see now talks, gives his opinions. I can tell that he's interested in getting to know me. He tries to obtain my trust and thus makes me feel more comfortable. What type of therapy do you guys think this particular patient had experience with the first time when they said the therapist said, sit down and talk? Say again? A couple of you are saying psychiatrist. What type of therapy modality? where someone wouldn't respond and made the participant feel like they were speaking to a wall? Any ideas? Probably psychoanalysis, right? Anybody who believes that you need to be a blank slate and that you're not to interact, that you're supposed to let the person project onto you what their issues are, that's not very relevant to a lot of our Latino communities because there's no engagement, right? So we're very talkative, very expressive. You see, I keep moving my hands around, right? When the person went to a different type of therapist who actually talked back to them, right, demonstrated interest in getting to know me as a person, not just what are my symptoms, right, but who am I? What am I struggling with? So that's something that we also need to think about when we're explaining what we do or what services are available or when we're helping a family connect to services, to understand the different type of treatment modalities and what might be a better fit for this particular person who's seeking treatment. General attitudes towards treatment. As I mentioned before, a lot of our participants believe that depression is a consequence of difficult life circumstances, not an illness. So they recognize it as a problem, yes, but they don't see it as an illness the way they see diabetes as an illness, high blood pressure as an illness. And the implication of that statement is that they're less likely then to take medicine, right? Because if it's a natural reaction to struggles in your life, why would you need a pill? There's nothing wrong with me. I just have a stressful life. Feeling of trying to deal with problems on one's own. There's a high value on this idea of doing your part. Hay que poner de su parte, right? So why would I go seek help from someone else? I need to make sure I'm doing my part. I'm doing what I can. I need to struggle with this on my own. That's the value. Medication is only for people who are severely mentally ill. This is the concept. This is the way people see treatment, mental health treatment. So again, the first and the last points here are very, very interconnected. If you think that depression is a natural reaction to your stressful life circumstances, why would you need to take a pill? There's nothing wrong with my brain. There's nothing wrong with my body. I'm just dealing with life, right? There's a tendency to seek out a talking cure first. Again, that's connected to not going to immediately psychotropic medication as a treatment of choice. There's a general value in the need to unburden yourself, desahogarse, right? Medicine is seen as a last resort and, at that, as a temporary solution. There's a big fear of having to take medicine for life. There's a fear of side effects, the addictive potential of psychiatric medications, and this is based on misconceptualizations of psychotropic medications as being the same as street drugs, comparison to simple things such as coffee. Latinos, we like coffee, we like strong coffee. If we go one day without having our coffee, we get a headache, right? So there's a dependency all of a sudden on our coffee, on our nice strong cup of coffee. So they have that same model when they're thinking about medicine. Again, these are generalizations. So the fear of addiction is very strong. They use the model of sleeping pills and coffee, as I just mentioned, to understanding medicine. Over time, people need more and more to have an effect, and it's difficult to stop. This is the huge fear. So when someone comes in and is struggling, talking about depression, and you say, well, you know, you could take an SSRI, or we have medication for that, I can link you up with a psychiatrist, you can almost guarantee that person's not going to come back. When a doctor directly explains the differences between psychiatric medication and these other general models that they're using, and that medicine can be stopped, people are much more likely to accept the medicines. So again, psychoeducation about what we do, how we do it, what treatments are available, and how they work. And making sure we invite the client in the room to ask their questions, to explain what they're using as their reference in terms of how are they understanding things. It's extremely important that we remain open to that conversation, that we invite that conversation time and time again. Here are some quotes to describe what we just discussed. We Hispanos have become accustomed to using home remedies. In reality, medications are not very well received by the Hispanic community. What are some home remedies that you guys use or have heard of, whether it's for psychiatric medication or otherwise? What are some home remedies that you are aware of?
When I worked at St. Joseph's Hospital with the pregnant teen clinic, and when the girls would come in pregnant, we said, was this planned or not? They say, oh no, it wasn't planned. They said, oh, what did you use? They said, I drank warm milk and took the aspirin. That's my birth control.
Warm milk and an aspirin. Excellent. Anyone else have other experiences with home remedies?
That's a good one.
That's a good one.
Go ahead.
A lot of the clients that I have worked with, they use teas.
Teas, yes.
You know, like té.
Right.
You know, de manzanilla, chamomile tea. And, but also, before that, you mentioned something about going to the doctors. You know, sometimes a lot of the clients that I work with have tried other remedies first. They have gone to, you know, curanderos.
Sure.
You know, and they have gone. It's almost like a typical therapist session.
Okay.
You know, you go in to visit them, you explain the problem, they prescribe some herbs, you know, or whatever, or they do whatever they do, and then they send you home without prescription, and then they go home and take it.
Right.
So they usually try that. A lot of my clients, they try that first before they come.
That's true. There generally is a progression, right? Because again, keeping in mind that they're seeing psychiatrists and psychiatric medication is the last resort. So there's usually a progression of other things they've tried prior to that. They've tried talking to friends, family, perhaps spiritual leaders, whether that be an institutional religious group or traditional healers, right? You mentioned curanderos. Using teas, home remedies, then maybe going to their primary care doctor, and then maybe eventually, hopefully, landing in mental health treatment. Right? But you're right, there's usually a progression for that, but teas are a very big part. Teas, baths, have you guys heard of clients who use particular, like rose water baths or orange blossom, right? God bless you. So home remedies are really important, a part of our tradition and what we do for anything from psychiatric problems to, you mentioned birth control, you know, ways of curing a headache, like anything, you know? So it's important that we also ask them what they've tried, what has worked, what hasn't worked. Yes?
I find it interesting. I work in an emergency room setting in a crisis center, and a lot of times we have clients that come in who have used oils of various kinds and prayer.
Okay.
They will pray, and I mean pray for hours, you know, nonstop. And a lot of that, you know, is part of their ritual for relieving whatever the pain that they're feeling is, you know, that they experience or express. We've noticed that, interestingly enough, there's a comparison that we've noticed between the Latino population that comes in and the Hasidic Jewish population members that come in.
Okay.
And in crisis, you know.
Right, that's an interesting parallel.
Yeah,
but yeah, the role of prayer.
The use of oils and prayer and the rituals that they will.
When you say oils, do you mean like aromatic oils, like lavender to help them calm their nerves or things like that?
I mean aromatic oils, I mean religious oils, or oils that they brought, which they thought were religious inspired, or, you see what I'm saying, have been passed on to them.
Right, I see.
From religious leaders.
I see.
Yeah.
Yeah, that's a very good
Charles,
point.
so what gets them to finally come to the screening center?
The fact that they've gotten so bizarre and out of control that it's brought the attention of either neighbors or the police or both, you know, or family members have just said, well, you know, I mean, they're holding, they're retaining fluids, you know, I mean, gallons and gallons of water in the house, or they're doing bizarre sort of things that they've said, no, this is, you know, this is wrong, or this is, you know, yeah, extreme in some way. And so they said, you know, now we think they need help. They need another kind of help.
So there's a recognition of when you're using sort of traditional.
Has broken down.
Right, when that has broken down, exactly. When it's gone too far and become bizarre.
Yes.
Usually, I used to work in a mental health clinic, inner city, right here in Trenton. And a lot of the primary care physicians will refer them to me to make an assessment because they were either threatening suicide or doing some other life-threatening situation.
So high-risk behaviors.
Whether they will be, they will make that decision themselves, or whether they will force them to go.
I see. So that was how they entered treatment. The primary care would refer them to you. Interesting. Yeah. Any other comments or questions about what we've covered so far? Thank you all for your participation. It makes it a lot richer. We talked to them about how do we improve care for depression. So some of our participants, as you surmised, had already had some experience with trying to access care. Some of them had not. So we asked them what would make a good therapist, or how can we improve treatment for depression. The overwhelming response was therapists needing to be sensitive of cultural expressions of cultural expressions in general, but of depression in particular. We talked about somatization. There's a lot of literature showing that Latinos as a group tend to express their emotional pain physically. The concept of coraje, which is interesting. When I say coraje, those of you who speak Spanish, what do you interpret that to mean?
Pissed off, angry.
Anger, rage, okay? In some Latino subgroups, coraje means courage. So even if we speak Spanish, it can mean different things, so we need to be aware of that. And also the concept of nervios. Have you guys heard of nervios, ataques de nervios? We have the international expert on that sitting with us right here. Therapists need to orient Latino patients to the process of mental health treatment. And I've been infusing my talk with that very important concept all throughout. They don't know what to expect. It's our job to help them understand what that roadmap is so that they can make appropriate choices. Therapists need to directly explain medications and address concerns about addictions. Again, being very open and inviting that conversation. However bizarre or off the wall you might think it sounds, but it's important to know where they're coming from and what their understanding is, because a lot of times they'll say, yes, 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 okay, I'll follow your treatment, sure, 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 and then they're going home and doing something else, right? So if we don't invite that open conversation, we're not going to find out what's really going on and what might be potentially a barrier to treatment that we're not aware of.
Yeah, I think sometimes therapists feel like if they bring up the issue of addictions, that will somehow get people to be afraid of it, and so they don't bring it up. But in fact, it's there. And I think that's our point. So it really is, if you bring it up, it kind of relieves things, because it's not like people haven't thought about it.
Right. In terms of needs for community intervention, we need programs to help Latino immigrants adjust to life in the United States. We talked about some of the problems and difficulties that happen when you migrate here. There's a lot of questions, there's a lot of unknowns, so we need community programs to help orient immigrants. Programs to reduce the stigma of mental illness and mental health care. Again, this idea of you have to be extremely crazy to go and talk to somebody to get help. That is a huge barrier to care. So the more information that we can provide and the more we can really get out there and find out what their fears are, then we can address what's behind it. And public information in Spanish about where to get mental health and how to access care. Again, sort of psychoeducation, making things easily available, readily available, so that they have an easier transition into care when they're struggling with all these difficult life situations.
I think, given that we have a couple people here from the school system, I think I'd really want to put in a plug about the schools really being a place where you can do a lot of orientation and helping. I don't know if you have a welcome class or some kind of program to welcome kids who are new immigrants, but also sort of working with the other kids about how to welcome new immigrants more effectively, because you've talked a lot about the stigma of speaking Spanish. Kids always talk about, if they bring their tacos to school or they bring their rice and beans, the other kids laugh at them. They don't, they want to bring pizza or something like that. So, so I think there's a lot the schools can do, but they often don't think about it as a way to
in our school, we once a year we have a multicultural luncheon, because we have, even though the majority are Latinos, we have a heavy Bengali population in my area. So once a year we have a multicultural luncheon, and they do bring their rice and beans, and they do bring their plantains, and whatever represents their culture, they bring it. So, which is good. I mean, I rarely see anybody bring American food. It's usually they're happy to bring any share. Their food.
Yeah.
Right, they bring in all the Spanish food.
Yes.
And I was thinking also, you need to start with the adults as well. And one of the things that our district has started doing is having trainings on cultural awareness.
Okay.
And just talking about, some of the things that we kind of unconsciously do with our children. If they see us having a reaction about something, they pick up on that. So we as the teachers and the staff in the classroom, we have to also kind of teach the children to be more culturally sensitive.
Right, so as the adults, we need to model that cultural sensitivity, right, and cultural awareness.
Yeah.
I know a lot of parents came to me complaining that the schools will refer the kids to the doctor because they had ADHD, you know, and because the kids were all over, not talking nonstop, and a lot of these kids were immigrants, you know, that were recently here in this country, and they were deadly set against medication.
The parents didn't want their children to take medication.
Then, you know, I had to explain to them about the benefits of the medication.
And did they explain to you when you were discussing medication some of the fears that I covered here?
Yeah, they explained all those fears. They worry that the kids will become addicted and all that. And then when I explained to them that the kids will have a better chance at learning, you know, if they were able to take the medication and to be able to focus and learn. Otherwise, they would just continue to be that way and never learn or assimilate information that was being taught. But my point was that a lot of times, a lot of the teachers were having a lot of difficulty with some of these children, and they will immediately label them as ADHD, when actually they were just not able to adjust to it, you know, to the changes.
Right.
Yeah, I think a lot of times, I know when I worked with the school system, a lot of kids were misdiagnosed in child study teams as learning disabled or problemed, and the parents didn't really understand because they didn't really go to a lot of these parent-teacher conferences. So you sat with them and said, well, this is what this is all about. Or they saw a letter, they didn't understand it. They were just like, leave it, and like, oh my God, what are you doing in school? You're being bad.
Right.
So, you know, it's a lot of times it is a language barrier and a cultural barrier.
There's a huge disconnect, right, between what the school process is or some of these institutions that we have and what the parents know, expect, or understand. That's a really excellent point. Go ahead.
And also, a lot of times, like when you were talking about how clients go to talk to a doctor and they're talking about their symptoms, it's easier for the parents to go for help because it is the kid who needs having issues, whatever. So talking to the teacher, it's when they are aware that a lot of these things are going on at home, it's like opening a door for the parent because, yeah, the kid needs help. There's behavioral issues or something. But that's like how we get at the mental health clinic where I work. That's how I get to work with the parents.
Through the children.
There's a lot going on, but it's easier for the parents to accept that because, oh, my kid is having some issues. But when you talk about everything that you were saying before, it's like, that's why the kid is having the issues.
Exactly, and if you come from sort of a family systems perspective, that's exactly right. The idea that children love their parents and their families so much, they actually carry the symptoms for the family, and that's their role.
I just want to say, first of all, we have an issue with teachers, using the term ADHD, and I work on a child study team, and we're always constantly educating them. First of all, you're not a professional, a medical doctor. You may never use the term. You can describe symptoms. Your child is fidgety. Have you noticed that at home? He's having difficulty sitting still. Now, in our school, every child should know he should raise his hand because in the classroom, it's supposed to be school and class rules. So the teacher goes over them in September. So if it's school, that child doesn't know he's supposed to raise his hand, that teacher should have had the rules there because you know you don't get out your seat, you know you don't put your hands on anyone. And that is like the core of how you begin classroom management. So I'm concerned that child didn't know he's supposed to raise his hand.
Right.
There's some miscommunication somewhere from the day one.
Right.
And I just like to talk about with the child study teams, we see so many children that are referred to us because they're not functioning. We have to, number one, tease out, is it a child not learning because he's a language barrier?
Right.
Because if you sent me to Turkey and you ask me what 1 + 1 is, I'm not going to tell you the answer because I don't know what you're saying. So we first try to tease out children who may have learning issues as a result of possibility of language barriers. And we really, the teachers are pressured right now with our lovely governor to push accountability. In Patterson, we have some of the lowest performing schools in the state. And so teachers are now pressured to get, the classroom, the core curriculum content down. And if kids aren't performing, and many times Latino children are functioning 3 and 4 grade levels below. So what they're doing, they're referring to a child study team. And many times we do find that there's a learning disability. Number one, that parent that can speak English, she can't help that child read. She can't help that child with the homework. If a child is struggling, who do they get to help them?
They're delayed emotionally.
And that's a big issue.
It's a really big deal. And one of the things at the school where I work, for example, they're able to do the testing. The IEP team can actually do the testing in English or Spanish.
Yeah, we do that.
So that also helps tease out some of that. But you're right, a lot of things they're very easily misconstrued. The teachers don't know. They're under a lot of pressure. In this case that I was talking about, this child came to the school middle of the year. So the whole first classroom management orientation, they missed that. And that goes back to Dr. Guarnaccia's point of, does the school have some sort of program to help new immigrants acclimate, understand the rules of the school, of the classroom, et cetera, for both the children and the parents. Okay, this is one of our favorite all-time quotes, all right? It kind of makes a little bit more sense in Spanish, but I'll describe it in English, all right? So one participant said, what do you do when you have a problem? You worry. But to resolve a problem, you have to take off the pre, because in English, preocuparse means to worry, and take care of it. Ocuparse means to take care of something, to deal with it. So that's why the quote makes a little bit more sense in Spanish, but the idea basically is there's a recognition that it's natural human tendency if you have a problem to worry about it, to think about what am I going to do, what did I do wrong, what could I done, shoulda, coulda, woulda, all that, right? But that can only get you so far. At a certain point, you have to do. You have to actually get up, you have to take action. Okay. Moving on to sort of general topics of Latinos and depression. Immigrant Latinos experience lower rates of depression than US-born compatriots and the non-Hispanic whites. So here I was just spending all this time with Latinos and depression, and now I'm telling you that immigrant Latinos experience it at lower rates. So why is that? However, Latinos are more likely to endorse depressive symptoms on a checklist. Give them any one of these checklists, the Beck Depression Inventory or anything like that, and they're more likely to check everything off, yet they're experiencing it at lower rates. Why is that, right? And this goes back to this idea of reporting things, of having these somatic complaints and physical representations of emotional distress. Latinos are less likely to seek mental health services when they are depressed compared to whites. Immigrant Latinos have lower rates of service utilization compared to US-born Latinos. So again, these are some of the issues that we discussed in this other study that I just presented to you guys. So these points are based on national studies that have been done comparing different groups of US-born Latinos, immigrant Latinos, and non-Latinos, whites who are from here. Studies show that minority group members have additional concerns when entering treatment centers. What am I talking about? So if you are the sort of reference group, right, you can go in, you understand the culture, you understand the social schemas, what you're supposed to say, when, where do I sit, how do I describe, how do I address. When you're an immigrant, not only may you not be aware of all these sort of rules of the game, but you also are doing an additional scan of how safe am I here? Does this person understand my background, where I come from, what I struggle with, my experiences since I've been here? So there's an additional scanning and working that's going on in the brain. And that takes a toll. That's a lot of work. Latinos are more likely than whites to have negative beliefs about antidepressants. We talked about this concept of the fear of the addictive potential of medication. And Latinos may not initially seek treatment for depression because they see it as a natural reaction to life's problems, not as an illness. Again, we discussed this earlier. Some of our work saying that they show preference for psychotherapy or the talking cure before medication, the fear of addiction, stigma, the value on desahogo, this idea that you talk it out, you unburden your soul by letting it all out, leads to this idea of preferencing talking cures and psychotherapy as opposed to psychiatric medication. This is a different study that I'm going to describe to you now, okay? And this was a study that actually was a multi-phase study that was being done to adapt motivational interviewing techniques to increase adherence to antidepressant medication among Latinos. How many of you are familiar with motivational interviewing? I knew you would be. You're aware of it? Okay. So it was originally developed actually to help substance abuse and the addictions, people struggling with addictions. The idea being here, the idea behind this study was, can we use those same concepts to address the ambivalence that people have with taking antidepressant medication? The first phase of the study was doing focus groups and developing the adaptation of the motivational interviewing technique. The second phase was pilot testing the adaptation, and the third phase was doing a randomized control trial. What I'm going to be talking about is phase 1, the focus groups. The purpose of this study was to look at the cultural values that influence people's decisions to take medication or not, to understand what participants know about antidepressant medications and what fears they have about this treatment, and to ask whether or not participants are able to accept the treatment recommendations from their providers and what influences their willingness to accept that recommendation from their providers. I'm going to focus on this first one, the cultural influences, the values that influence that decision to take medication or not. The specific cultural value that I'm going to be talking to you about is this concept of familismo. How many of you have heard of familismo or familism? You've heard of it? Okay. So I'll describe it for you first, and then we'll go through the actual study and what the conclusions were. Familismo is this tendency to value family relationships over outside social relationships. It includes concepts such as respect, to refer the hierarchical nature of family dynamics, right? So the idea that you respect your elders, grandparents, parents, there's this sort of social hierarchy within the family. Familismo is a manifestation of the collectivist nature of Latinos, right? So what does that mean? It means that the benefits, status, and general well-being of the group takes precedence over those of the individual. That completely flies in the face of traditional US American culture. Familismo is a dynamic concept. So what do I mean by that? It represents family unity, respect, and responsibility. However, it can create both positive and negative pressures within the family. And it can lead to covering up, for example, the severity of one's depression or depressive symptoms in order to protect family members. Because again, the general status and well-being of the group takes precedence over the individual. This is the concept that is the new concept that's being introduced by this particular research that I'm presenting to you. Okay. So what we did is that we did these focus groups to talk about antidepressant medication, why they take their medicine, why they don't, what influenced them, right? And what we did was we coded them. When you have a focus group, you then get a transcript of everything that was stated, and you develop these codes based on what people actually said. As I said before, the data actually comes from the participants. We don't impose it on them. What we did was we coded all the instances in which family was mentioned. If they mentioned family at all, any family relationship, any family dynamic, we coded it. However, we noticed that wasn't necessarily describing this concept, this value of familismo that I just defined for you. There was a tendency to focus on more instrumental support. What do I mean by that? A family member who drove them to the clinic to drop them off. The family member who went to the pharmacy to pick up the prescription. That's what I mean by instrumental support. This concept of family and family influence was important in the individual's conceptualization of depression and or its treatment, okay? So family members could directly challenge or influence the client's understanding of their illness, of their treatment, and also their behavior. So as I mentioned before, this was a multi-phase study. The results that I'm presenting here are from that phase 1, the focus groups. We did 6 focus groups for a total of 30 participants. They were completed between the months of April and August back in 2006. The average group size was 5. They were all audio taped, transcribed, and analyzed using this software package called Atlas TI. A little bit about who our participants were. Most of them were female, 80%. Huge age range, 27 to 66, with the average participant being 47 years old. We asked them about how long they had been in the United States. And again, you can see this huge range. Some of them were here a year. Some of them had been here 40 years. The average participant had been here 18 years. Time with MDD, that means time since they were diagnosed with major depressive disorder, okay? And again, we have a range. Some people had been diagnosed less than a year ago at the time of the actual focus group. Some of them had been living with the diagnosis for 30 years. The average was 11 years. Time on medicine, time that they had been taking antidepressant medication. And again, we see that huge range, less than a year to 24 years with an average of 9 years. Sample characteristics in terms of where were our participants from. 50% of them were from Puerto Rico, 23% were from the Dominican Republic, 17% were from Mexico, and 10% other. We had Colombians, Argentinians participating in our group as well. 73% of our participants had completed a high school education or more. 80% of them felt that they read Spanish well or fairly well, so we're looking at their Spanish language proficiency. And 83% said that they did not speak English well. So what do we have here? We have a group of almost monolingual Spanish-speaking women. So 73% spoke mostly Spanish with their family, and 63% spoke mostly Spanish with their friends. Okay, so again, it just gives you a sense of who was participating in our groups. Cultural considerations, familismo and family influence, right? So now I'm going to talk to you about the actual data and how we coded it and what it meant. The concept of familismo was coded 50 times across the groups. Why does that matter? Remember, this was a study to look at why do you take your medicine or not for depression. We didn't ask them about family, but it came up 50 times, okay? So that 73% of our participants mentioned family when we weren't directly asking about it. That means it's important. That means it's extremely relevant to their decision making, right? Family influences, which is sort of the way that families help you out, take you to your appointments, get your medicine for you, was brought up by 80% of our participants. And again, we were not directly asking about this.
But I mean, isn't that logical? There we go.
No, go ahead.
You have a group of women,
right,
who are mothers, family members. I mean, these are women who pretty much raise and nurture and culture, you know, and pass the culture
right
to their family members.
Correct.
So wouldn't you naturally expect that this group of sophisticated women, women, you know, who are raising and bearing the culture of their families, be the ones to be more family-centered and focused?
And family-oriented?
And family-oriented?
Yeah, you're right. I mean, there's a lot of sort of implicit and inherent sort of gender roles that would lead to certain expectations. And we weren't surprised by this at all in our research. But my point is that we weren't asking about how does your family influence whether or not you take your meds. We never asked that. That came from them.
Well, you know what I'm wondering, right? Sitting here like this.
Go ahead.
We're the men.
Right. Well, that's a whole other gender issue of who's more likely to seek treatment, right?
Right.
But I think the other implication of your question, Charles, is so how many of your programs routinely do family therapy?
Right.
I mean, if it's so logical and so obvious, why then is it every meeting a family meeting? Or at least, you know, a major portion of the meetings a family meeting? Why are we, you know, why do we have one chair in our office for the patient and we don't have everybody else coming in on a regular and mobilizing them to support?
Right. So that's sort of the point, right? So it seems logical, and yet our practice doesn't match it. We don't include family members when we're discussing treatment options with our clients. We don't have our offices set up to make it family friendly, right? So these are sort of implications, and we'll move forward with that. But I thank you for your comment. So again, we didn't ask them about familismo. We didn't directly invite that type of family value in our discussions, but it came up from our participants. And one participant in particular described familismo very, very well. She said, we care for our children, our parents, everyone very much. We want to always be united. And even when they get married, meaning the kids, even when the kids get married, one wants one's grandchildren, everyone, to join together in the family. We're very united families. Right? So there are families who say, oh my God, I can't wait for the kids to turn 18 and get out of the house because then it's my time, right? So what this person is expressing is that that's not the value that they were expressing as a Latino cohesive group. The concept of respeto, respect, why does that matter? one person said. Another thing I don't like about here, meaning life in the United States, one can't say anything to one's children. They do whatever they want. Here, there's no youth, and the children are the parents, in a way. They don't obey or nothing. In our countries, no. Even in my old age, I obeyed my mom and dad. So we're talking about these kids who are running around in the classrooms, doing whatever they want, teachers mislabeling them as ADHD. When children, one message that comes out loud and clear when children are in our institutions, educational or otherwise, is that if anyone lays a hand on you, you call 911, right? Your parents cannot do X, Y, or Z. These kids come home and tell their parents, guess what, Ma? I can do whatever I want, right? And the parents feel like they're losing their authority. They don't know what the rules are here. How can they discipline without getting in trouble? And that creates a huge disruption in that hierarchy that I mentioned before that's implicit in our culture.
Another issue I've heard come up is that young adults will say, when I was a kid, it was so hard because when I'm home and my mother or grandmother's yelling at me, I'm supposed to look down, I'm supposed to look very ashamed. Then I go to school and my teacher's yelling at me and they say, don't look down, look at me in the eye. You know, don't look away from me, you're supposed to, and they say, you know, how am I supposed to balance these different rules? I've got one set of rules at home, another set of rules here, and it's very complicated.
Right. So even the concept of respect is different in different cultures, right? So we expect in our schools, look at me when I'm talking to you. But in a lot of other cultures, you do not look a person of authority in the eye, right?
I also noticed that a lot of my parents, they feel very frustrated because they do discipline their children like they know how,
right,
through generations. And then if the child goes to school and have a minor bruise, then they immediately have to call a typhus to come in and investigate. And then when they come to their homes, a lot of the parents complain to me that they feel very violated. Because they come into their homes and they immediately believe that you were abusing your child.
Exactly. There's an assumption of guilt, not innocence, right? So it's very difficult.
Yes, it's very difficult, and then they lose their ability to parent these children.
Right.
You know, they don't want to bother with them. Well, just let them do it. Let the system take them.
Right.
You know, he's a problem.
Right.
You know, so it's a lot of conflict.
Yeah, so there's that loss of authority, even just authority over your own space where you're living, right? And I'm working with another family where the state had just been called, and as with so many of the immigrant families, there's one apartment, a 3-bedroom apartment. Each room has a different family, entire family in each room. So when the state comes to investigate, they're like, we were here for a neglect case or an abuse case, allegedly, right? And now we're seeing there's 3 kids in one bed, there's this and that. So then all of a sudden there's all these other things that come up and the parents are deeply, deeply ashamed, right? And maybe because of their legal status, they don't have access to certain programs that would help them find housing or get certain things. Or maybe, you know, because of their, again, legal status and financial difficulties, they can't afford an entire apartment on their own. So it really disrupts the family. And I'm not saying you shouldn't call it in because we're all mandated reporters, but there are sequelae to this that maybe when we're working with the family in treatment, we can help them address and work through it.
Just as a follow-up to that, I remember my son was little, and I do agree that that system has told these children, because something my son did, I said, you know, you have to have a punishment. He says, Mom, I know the only thing you can do is send me to my room or take me, because you can't do anything else, because we've been told there's this agency called DIFAS. So they are socialized. They tell you,
right,
you're going to send me to my room. That's all you're going to do. Right. So what's the big deal? I mean, and that creates really a challenge. Because I said, I can't tell you what I said, but, I want to make another comment. When I worked at one school, there was a little boy, going back to DIFAS, getting involved from minor things. The little boy slept on a mattress on the floor in the bedroom with her father. DIFAS came to the school and they told the father if he didn't get the mattress off the floor and get that child a regular bed, now the room was clean, just had a mattress, didn't have a frame, that they were going to remove the child. I said, don't you have bigger things to fry? I mean, the child is in a clean room, he's in an apartment, the mattress is on the floor. I mean, the father had one afternoon to get a frame for the bed, or they were going to remove that child.
Right. Right. It's a very unfortunate system. The other thing to follow up on what you're saying, when the child does sort of threaten the parent, you know, well, I'm going to call the police because I know the only thing you could do is put me in timeout or send me to my room. I'm going to call a state agency. It frustrates the parent to know, and it takes away their authority, but then it also starts this negative cycle. A common response that I hear from a lot of the parents that come to work with me is, well, you know what I told him? I told him, go ahead, call the cops, right? Or I'll call the cops before you do. And then it's like this very strange dynamic, this very negative tension and dynamic of everything is punishable, everything is calling the authorities, and you lose that, what you were mentioning before, the generations, the traditions of how do we discipline, some of them which are, you know, discipline practices that we can endorse here, and some of them which obviously we cannot, but it's an awareness of what the repercussions are, and can we work with the parents prior to that to educate them about our system here, educate the children as well, so that they're not also miscommunicating to the parents. You had a comment?
Well, it's funny because when I work for DIFUS, you will get really crazy calls.
Mm-hmm.
Of course, you have to check everything.
Of course.
But I think it's very important not just to walk into someone's house and just open refrigerators or, you know, you kind of talk to them, and once there's a trust, you said again, respect and trust, and then open up to, you know, other things. So it's a lot to do with people in general and the way you take up, because mandate, you have to report things.
Absolutely.
You have to also culture. Is our culture, as being a Latino, I know I grew up in that culture, you know, so you have to kind of balance it out and still, you know, get that through. Well, you're doing it, and this is the reason why.
Right.
You know, and then things get a little less tension, because if you walk in, you walk into someone's home, you know, introduce yourself. Hi, I'm, you know, so-and-so, and this is why I'm here.
Right.
And then, of course, you know, confidentiality, there's a lot of things that,
so what you're saying is very important. It goes back to sort of this sensitivity and awareness for anybody who's working with any family, right? Whether you're from a state agency, whether you're from the school, whether you're from a clinic, you know, you need to understand how you're coming off, how you're being perceived, right?
And that's, I think, in any culture.
Absolutely.
Because it's not only the Latino culture.
Of course.
I know I've worked with Chinese, Russians, Haitians, and, you know, there is a set of culture.
Right. Absolutely.
And a lot of them interact. And
there's a lot of overlap. Yeah.
You know,
there's a lot of
Asian
overlap.
and the Latino. I mean, in my daycare we had a Latino dancing, Chinese dancing salsa. It was great.
Perfect. Love it. So again, this just goes back to sort of explaining our roles, explaining what we do, what we don't do, and what they can expect. Okay, the idea of caretaking and functioning. What, in terms of, we asked them, what were some of the things that motivated you to seek help? So you knew you were struggling, you know you were kind of feeling down. What made you go that extra step? How did you end up in mental health treatment? This particular person said, what motivated me was my family, because my family right now is not with me, but soon my daughter and my wife will come. So then my problem was that I didn't want to talk with anyone. I did not trust anyone. And what motivated me to take the antidepressants was wanting to be well for when my wife and my family came. So this is, you were asking where are the men? This is a guy who was speaking, or one of the men who participated in our group. And he started talking about also the importance of family and his role as being a caretaker and the need to be well so that he can fulfill that role. He needed to get himself together. He needed to figure it out before his wife and daughter joined him from his country of origin. Another person said, this was a mother who had 2 children, one of them who was developmentally disabled. And she said, to see that it was they who were already bathing him. So her other children were bathing the child who was developmentally disabled, feeding him, because I spent my time crying, lying in bed. That was what made me finally seek treatment. Of course, it was I who needed to make myself responsible for my son and let my other 2 children have their childhood. So again, really strong, this idea of what your role is in the family. That can be a very, very strong motivating factor for folks coming into treatment. Now we get into what I said, the flip side is, remember I described familismo as a dynamic concept. It's not always all good. It can sometimes lead to negative pressures as well. One person said, I do not share my problems with my family because I do not want to bother them. When they ask me how I'm doing, I tell them that I'm fine or that sometimes I feel sad, so I do not worry them. And then everything else, I tell the doctor. So this particular person was very engaged in treatment. But here we talk about how this concept of protecting the family can sometimes lead to not being honest about how much in distress you really are. Again, one person said it's preferable for one to speak about these things with someone in particular, meaning someone outside, rather than with my own family. With my children, I do not say anything about what I feel. But you know, I sometimes feel it would be good to be able to speak with your kids or with the family and share the pain that one feels. But in the end, what you get are problems, more problems. So here we have a person who has basically they have to compartmentalize their life. Everything's peachy, everything's fine when they're talking to their family, and they have to hold their pain for the sessions that they have with their providers.
Can I mention something about that? Because I worked in the field of addictions for many years, and what we noticed was that a lot of males, Latinos, would come into treatment, but not Latinas.
Okay.
Because to have a father or an uncle that was a drunk, oh well, that was expected in the culture. But to have a mother or a wife or a daughter, that was a burning shame.
Of course,
One of the worst things that you could have. That's why a lot of times Latinas, although they might have problems, they will keep them in their home. Isolate them and kind of.
Also, like she said, with domestic violence, you know, everything's under the rug because, or minimized because the man is machismo. You know, this is he runs the show.
Right.
Especially first generation, not
Right.
second or third. But it's it's a big problem.
Right. Yeah, we actually did have a lot of.
Come hand in hand.
Right. They do come hand in hand, and we did see some domestic violence problems come up in our focus groups as well. It's important to recognize that. So I was talking about familismo as a value of protecting the family, sometimes even to the detriment of the self. Now I'm sort of switching gears here to this concept that we called family influence. This was mentioned by, we talked about how family influence can either be treatment supportive or treatment discouraging, all right? So we broke it down. 60% of our participants mentioned treatment supportive family influences, for example, helping them access care, providing support or reminders to take medications, helping to obtain the medications, going to the families to fill pharmacies to fill the prescriptions. But then we also talked about treatment discouraging family influences. This came up less frequently. We have some hypotheses about why that's the case, but 30% of our participants did mention a treatment discouraging family influence where the family members expressed disagreement with the concept of depression as an illness or the need for medication as treatment. And I'll give you some examples of how that came up. So here's an example of treatment supportive family influence. One person was talking about their family member. She goes out, she tries to find the money to buy the pill. If she sees that I'm short, she looks for it. So she'll try to find a way to get more pills. When I leave it at the pharmacy, she'll go and pick it up for me. If for any reason I don't have time, she always tries to pay attention. She says to me, "Do you have your pills with you?" So again, family is kind of being aware, helping the client remember, you're supposed to take this medicine. Treatment supportive family influence, again, my sister was the one who took me to the clinic. And I was wherever she took me, I would go. So this particular participant was sort of lost and was, so down on herself that she just was going wherever her sister would go. She wouldn't leave her side, and her sister brought her to the clinic. She was the one who would say to me, "Gloria," these are all pseudonyms, by the way, "you have to take this medication." And I would say, "What's that for?" And she'd say, "To cure you, so you can be well like before." So here's a very simple statement, but here's a family member very much endorsing the need to take the antidepressant medication to help the patient get better. What are some examples of treatment discouraging family influence? My parents taught me that we could deal with problems without medication. And the minute I started with the medication, I felt as if I was from another planet, let's say. It was something that was out of my hands. So all of a sudden, this idea that now you're taking medication, it's this crutch, you're so out of it that you now have to rely on this external pill. And it's like being in another world, another planet. So the family members told her, you're supposed to deal with things on your own, not with medicine. So they're not supporting the treatment here. Here's another example. Sometimes my mom says to me with all the problems that I've had, and I've never gone to a psychiatrist, what did you fail in? What did you do? And I will Everyone is different, I tell her. Maybe you could deal with your problems, but I can't with mine. So here we see an example of a mother-daughter. This is an adult daughter with her mom. She's trying to advocate for herself, but the mom's making it very clear. She failed because she's now seeing a psychiatrist. There's something wrong with her that she couldn't do right. That's really, really influential.
So I just want another example, and I think what we found is the importance of understanding different religions in the Latino community. I was involved with a study where we were evaluating Latino bilingual bicultural inpatient psychiatric programs in New York City. And one case came up where a patient who was hospitalized was given a furlough. This was a longer term to go home and visit his family on weekends. And the staff noticed that when he did that, he would come home, he would come back to the hospital in really bad shape, hallucinating, out of control, whereas while he was in the hospital, they found out that he was a Jehovah's Witness, Testigos de Jehová. And so when he went home, his family said, you know, this medicine's bad for you, let's pray. And somebody actually mentioned that earlier. And so they would pray together, they'd pray for, but he'd stop taking the medications. And so by the time he was back and the medications were out of his system, he was not doing well. But so it's really important because, you know, we have this image that Latinos are Catholics, and obviously there's lots of religious diversity, and some of the religious groups are pretty discouraging about medication. So there's both the values that discourage it and also some religious practice.
Right, and I think also sort of piggybacking off on that, with children, for example, who take medication for ADHD, sometimes they have it set up so that the school nurse will dispense the medication first thing in the morning. And then what you'll find is the children are having sort of medication holidays on the weekends or on spring break or whatever the case is, because maybe the family really is ambivalent about giving the medication, but they have it set up because they kind of want to give their child the medication, but it's being dispensed by someone else, so they don't necessarily have to own it. But when the child is home, the parents don't want to give the medication. So again, the way family can influence adherence with medication. Another thing that I want to go back and say is that I gave the example of the person reminding the patient, take your medication, which I gave that as an example of treatment supportive, right? But can you think of an example of why that very same behavior may be not supportive, maybe treatment discouraging? Can you think of a context where that very same behavior, a family member reminding you to take your medication, why that may not be perceived as supportive?
Sometimes I think that the client, when you have a parent or a spouse over the client trying to make them take their medication and remind them constantly, they never have to be responsible for their own, you know, so that kind of, he becomes dependent on someone else instead of being independent, taking care of his own illness.
Okay, yeah, so that's a very good idea that depending on the context, it can create a codependency, right, where then the patient all of a sudden is unable to remember on their own to take their medication. Did you have another idea?
Well, a lot of times I find that also parents or adults put a lot of stress on the children. Translate, you do this, and the kids don't even know what's going on, and they get, you know, call the pharmacy, do this, why do I have to do this? So the roles reverse, and it becomes very stressful for the kids.
Right, so then if the child is in the role of telling the parent, take your medicine or whatever, that can become very stressful for the child and then create another problem. That's an excellent point.
I was going to also say that constant reminder to that patient about taking medication for the patient may validate, I must really be crazy. She's reminding me to take my medication, so I really must be nuts.
Yes, yes, exactly. So then it sort of is constantly reminding the stigma and you're a failure, you need that medication, right? One thing that came up was we had a woman who was in the focus group with us who's, anytime she became upset, right? Let's say the Con Ed bill came higher than what she was expecting. So she's like, oh my God, where are we gonna get the money for this? And she's upset. And the husband comes over and says, honey, you're really upset. Did you take your medication? Is that treatment supportive? No, because now all of a sudden normal emotion is being categorized as part of the illness. So that's where the context becomes extremely important to understand the behavior. It could be treatment supportive or not. It could contribute to the stigma, it can create other problems within family members and burden, and it can create dependency, as you guys all mentioned. So the summary, what's the sort of take-home message? Are families important in Latino communities? Absolutely. Familismo served in some cases as a motivating factor to seek treatment, in some cases as a trigger for the depression. A new issue arose within the value of familismo, the idea of protecting the family from the self. This is a sort of a nuance within this concept of familismo that hasn't really received much attention, where you might negate the self to the point where it's detrimental to yourself because you're protecting the family. Family influenced the ways that focus group participants understood their symptoms and viewed their treatment. So what did we learn? What cultural values influence people's decision to take medication or not? That was one of the major questions from this phase 1 of the study, as I mentioned before. I spoke to you about familismo. That was the focus of my talk today. But other things came up as well. Religion, which we spoke about in different dynamics. This idea of poner de su parte, do one's part. I mentioned that from the other research that I discussed. And also this value of working, struggling, taking advantage of what the United States has to offer. We came here for something. It's our role to be active, take action, do what we need to do, take ownership for our problems, and deal with them. And what does that mean? That means that maybe then you're not going to admit that you're not having a success in those areas, and you might not go to treatment, because that means facing the reality that you're struggling maybe too much, or maybe that struggle is too much of a burden for you. What are the clinical implications of these results? Clinicians need to be culturally sensitive. We talked about whether you're a caseworker being assigned to investigate an allegation of abuse, whether you're a therapist, whether you're a teacher, whether you're a part of the school-based support team. You need to be culturally sensitive. It's not always wise to include or to exclude family members in treatment. So just because you're a Latino doesn't mean you need to shove all the family members into the room, because we just found out sometimes it can be not supportive of treatment, right? You should listen to the patient's own experience of the family relationships and decide together what would be in the patient's best interest. If the family is included, the focus should be on psychoeducation. So you can help them tease out what's part of the illness, what's a normal emotional response to something. Patients should be encouraged to take an active role in treatment planning. Patients should be empowered to negotiate with the clinician and to decide their family's role in their own treatment. Okay, so that's it. Did you guys have any other questions or comments about that part of the talk?
Or at this point, anything that we've talked about so far?
I was just thinking that last sentence.
Yes.
That's a real big one, because getting parents, say looking at child 17 work, to ask the right questions and make sure that they're clear on what they're signing.
Yes.
And you know, because you're sitting there signing legal papers, and I've had parents walk out the door and then they'll say to me, I didn't understand anything they were talking about in
Absolutely.
there. But they signed the papers.
Right.
And you have to make sure, like you said, that they really understand. You simplify sometimes, because again, you may have an educational thing going on there that they may not be able to read or write. I know with a lot of the seniors, I had that too, and you know, they were a little ashamed to tell you they didn't really understand, even if it is in Spanish or whatever, they don't. Right. So, and it's,
And from our side also, because sometimes we talk in, you know, our little
jargon.
And parents don't understand what you're talking about.
Right. I think the way to help, invite the parents to ask those questions is by putting it out there, by making it okay for them to ask those questions. Obviously having a translator if that's appropriate, but making it okay, normalizing it, saying, you know, a lot of times we have these meetings and parents are really confused and they don't really understand what we're saying. Do you have any questions about what I'm saying to you? And being really self-aware that we're not using that jargon, that we're not using those sort of clinical terms and sort of professional lingo that, you know, anybody who's not in that particular subfield wouldn't understand. Exactly. So really inviting that type of dialogue.
We use those ourselves.
Oh, absolutely.
It's become such a habit.
Yeah. I want to say Maggie Alegria, who was the principal investigator of the National Latino Study, one of her newer projects is something called the Right Question Project. And she's been working with community people to train them how to ask questions when they go to see their provider. And I think, you know, you gave some perfect examples of how training families to ask the right questions when they come to child study team. And again, just like Igda was saying, people don't know what to expect or how to come into therapy. They don't, and she's finding it's very powerful. And it's pretty simple. I mean, it's not, she has a whole program, a training program. One of the things that they did find is that the providers were not so happy about it. Because now all of a sudden they have patients who are coming and asking questions, the sessions take longer, they're being challenged. But of course, again, this is something that more educated patients do all the time. I mean, they're on the internet, they're checking out, you know, they come in, well, I saw this medication, is this one better than that one, the side effect profile look. But I think it's important to help families and even to think about, you know, could you do some workshops for families on how to get more out of this? Because I think particularly the child study team is such a critical process of bringing the family in and making sure that they really understand. And of course, I mean, it doesn't usually happen, but there are legal issues that you raise when someone signs forms and then they don't really understand. You know, that's really, it's both, it's unethical in a way to have someone consent to something, you know, whether we're doing medication consent or whatever, to have them consent to things.
But isn't it also, see, with all the confidentiality, we have to be very careful because with HIPAA, everything that we do, as we all know, HIPAA, you know, confidentiality comes first, even with kids who are 18, in high school, not to, and like, well, you know, you cannot really talk to that person. So that's another thing that we kind of have to explain to them, how important it is, you know, in treatment or school or anything, that you just don't go around, you know, talking to people about this and about your business, which is kind of confusing because, wait a minute.
Right.
So that's really, that's a big one, I think.
It came up, we did a study of family caregivers, and the Latino families would say, you know, when their family member was hospitalized, particularly if their family member was hospitalized and they didn't know it, like they got picked up by the police, went to the screening center, and they would call the hospital and say, you know, I'm concerned, I understand my and they'd say, you know, well, HIPAA, I can't tell you, I don't know that name. And then they'd say, yeah, but as soon as they're ready to discharge a boy, who do they think they discharge them to? I mean, now I can know everything, but before. So, and it really, I think, in terms of Igda's presentation on familismo, this whole idea that, you know, I mean, it just so totally goes against the family idea that, you know, you won't tell me about my own child. I mean, even if my child's 40, you won't tell me about my own child because, you know, of HIPAA.
Because of government things that we are also limited to because we have to follow with our licenses or with our laws, we have to.
So that's part of our role then, is to make sure that we're explaining to the parents the limitations of confidentiality. Even when we're working with a minor, if they're in treatment, the child still has rights. And that's something that's not easily understood in certain cases. So we need to make sure that it's not described as a negative thing. You know, as a therapist, I'm not going to say, listen, even though you're the parent, whatever your child says is not your business, and I'm not going to tell you because of HIPAA. You know, I'm going to say, obviously, you're the parent. I'm going to respect your your role and your authority. I want to create a safe space for your child so they feel comfortable talking to me. And if anything concerning comes up, I will absolutely tell you. That's a very different message, right? So we have to also be sensitive about how we're communicating.